Okay, so we're going to start the day with our surveillance droids and what's new from the galaxy. So our first speaker this morning is going to be Dr. Alan Bateman from the State Laboratory of Hygiene. Please welcome him.
Oh, it's actually really hot in there.
Do you want to use this or do you want to wander and use this?
I want to wander. Thanks. For the first regional meeting, I also wore my son's cape, but it only came down to like here, so it wasn't very intimidating. All right, let's see if I can do all these things. All right, so surveillance. I can't see either of the slides here. Maybe I'll just walk around. So I get to talk about surveillance this year. Lana and I kind of switch off every other year, and this covers a lot of information. So it's a mile wide and about an inch deep. Any one of these slides or topics could be an hour-long talk in and of itself because we do a lot of different things. We're involved in a lot of different programs, but I'll give you hopefully the overarching view of everything, and feel free to ask me questions throughout or afterwards. All right. Let's see. See if that works. Helps if the clicker's on. There we go. All right. So first off, I want to start with the take-home points. Clinical lab, your all participation in surveillance by both sharing the data and the specimens that you do is absolutely critical to everything that we do for both our surveillance as well as identifying the outbreak response activities that we do. So thank you, thank you, thank you. You guys are an integral part of everything that we do, and a lot of what I'm showing here is data and specimens that you all share. Secondly, we use surveillance data for a lot of different things. We use it for overall awareness of things that are transmitting, many different pathogens. We've been able to identify issues with commercially available tests, and we also do enhanced characterization of pathogens, whole genome sequencing, next generation sequencing, other types of things to be able to identify outbreaks and more fully enhance or characterize the pathogens that we care about, which is most of them, let's be honest. Also, this year's updated lab-based surveillance plan has been published and mailed out. It's also available on a PDF version on our website. So you are welcome to go there, and I'll show you a little bit about that very soon. So outline overall, first I'll talk about the lab-based surveillance plan, where to find it and what's in it. And then I'll walk through each of the surveillance sections, respiratory, vector-borne, enteric, AR, and invasive. And within each one of those, I'll start with, first of all, the purpose. Why do we do the surveillance that we're doing? What's the real end goal or goals? And then I'll talk a little bit about the different programs that we're involved in, either statewide or nationally. And then the specific requests that we have for data and or specimens for things. And then I'll show a little bit about the data and how it's used. So first off, lab-based surveillance plan. So here is the lab-based surveillance plan. We have detailed instructions in there, also a description of all the surveillance requests, web-based reporting instructions for how to report data, and then data summaries in the back. As I mentioned, this was mailed out a couple weeks ago, and it's also available on the website. And we review this every year. We start months in advance and really walk through all the requests, make sure that we really still are doing things with all of the data and specimens that we're asking for. Sometimes we drop some things, sometimes we add some things based on national and statewide priorities as they shift. And so I'll talk about those changes today as well. So here's our website, and to find all the stuff about surveillance, it's up there in the top there, lab, network, and surveillance. Also down in the bottom, click here to search in case you're wondering what types of tests we might do. If you wonder if we offer it or not, that's where you search for it to see. So if you click on that, Lab Networks and Surveillance, it brings up this tab. And way down at the bottom is this lab-based surveillance plan. And you click on that, that'll give you the PDF. So it's always available in addition to the printed version. We always have the PDF. I go here multiple times throughout the year as people ask, do you want this or that or not? I say, well, what did we ask for 6 months ago? That's how I remember it. Go right there to the plan there. In terms of web-based reporting instructions, these are the data, the summarized data that we ask for each week. So number of samples tested for influenza and number of samples that were positive. Number of samples that were tested for RSV or or any other pathogen that we're interested in, group A strep is another one, C. diff. We use these data weekly, we summarize them, and they're a really important part of our surveillance. So the way to do that, there are instructions in the plan. It's also at the same website. You click on this box right here, click here to report test results. And then it takes you to this web-based data reporting. This probably looks familiar to a decent number of people in the labs, but if not, each lab has a lab ID that they put in, and then there's one page for the PCR or rapid molecular tests, and another page for reporting antigen test results. And I should note, this type of data that we ask for is not usually the type that's reportable. So there's all the DHS individual reportable diseases like salmonella or measles or TB. These are the ones that are not reportable individually, but we still want to have a sense of what's transmitting and what's in season versus out of season. So this is a main way that we do that. So in terms of surveillance data, these are our requests for that data. A couple years ago, we had a bunch of different tables that had both the data and the specimen requests that we had all mixed in together. We thought that was pretty confusing overall. So a couple years ago, we split it out, and this is just the data table. So we have a few things that we ask for antigen detection-wise, a couple of the major respiratory viruses, rotavirus and group A strep. Then we also have a section for people who are running PCR, either individual or panels for respiratory, and then GI as well. And I think this is all exactly the same, except we've added back C. diff. We took it off a year or two ago because we didn't think that people were using it all that much, but we heard back from you all, clinical labs and IPs, that data is really important and is really useful. So this one's back by popular demand. We've added C. diff back to the data. And then at the end of the lab-based surveillance plan, we have quite a few data summaries. This used to be just influenza data. Yes, thank you for interrupting. Happy to take questions. What's that?
C. diff reporting, you only want if you're doing molecular. If you're doing antigen toxin, you guys don't want that?
I think it's PCR only. I'd have to get back to you to be sure. I don't want to squeak too much. I think it's just molecular. Alana, do you remember offhand? I don't think we got into the details of the multi-step algorithms and what type you're doing, what combinations you're doing. I think it was just the PCR test, just to keep things standard and more simple. So data summaries-wise, we have quite a few in the back, and they're in the back of the table, as well as in the upper left there. We also have a lot of graphs on our website that are updated. And then we also have an every other week summary of data that we send out, our lab summary bi-weekly. And here is a recent one. There was one sent out yesterday too, so this is not the most recent, but this generally shows the main things that are circulating respiratory and GI-wise. And we give a snapshot there on the right. And then we also, this is a place where we remind people about influenza in particular, because flu, what we're requesting specimen-wise changes whether it's in flu season or out of flu season. Like right now in the summer, early fall, there is not much flu around. We would like every single flu positive sent to us because those could be the weird ones, the novel reassortants, or maybe even H5N1. We really want every single flu positive right now. In January, there is no way we want every single flu positive. We don't want to have that burden of you all to send it to us, and what would we do with it? Like, there's no way we're going to test all of those. So we only want a small subset in January. And so this is where we update what our general request is. All right, so first clicker question, get your lightsabers out. Make sure they're on, unlike me. Are you signed up to receive this biweekly surveillance report? Yes, no, or what is the biweekly surveillance report of which you speak? That C option reminds me, I thought about presenting this whole talk in Yoda speak, and then I realized I'd probably just confuse myself even more than you guys, so you're welcome. I decided not to do that. All right, let's see. Looks like, yeah, we got huge participation. Sounds good. A few people still confused. I just talked about it. If you're interested, maybe a little bit more coffee. If you're interested, not signed up yet, email that wcln@slh.wisc.edu to sign up, or really talk with any of us at the state lab, and we can connect you with the people to get you signed up. All right, now for each surveillance section, we'll walk through those different things. I had to throw this picture up here. This was a couple years ago. My son wanted cupcakes for his birthday that had Darth Vader and stormtroopers on them, and that's a large marshmallow on top, and then my wife decorated them pretty well. So couldn't not show that one. I keep telling her that she should quit her normal job and become a cake decorator, but she hasn't gotten there quite yet. All right, so respiratory pathogens. Why do we do surveillance? Well, overall, it's to have situational awareness of what's circulating, both for all our awareness at public health, but also really clinicians to know what is common, what is not. Right now, it's rhinovirus, enterovirus, and SARS-CoV-2 are the most common two. In January, it's probably going to be flu if things continue as they normally do. And if flu is really, really high and a patient comes in and has all flu symptoms, you may or may not even need a test to just say, you have flu, and here's treatment if you need it, or if you might not need it. And I did hear just at our last week at one of our regional meetings, one of the laboratorians there said that they make their own summary that they send out weekly or every other week, and they include our biweekly surveillance report, and their clinicians really love it. So it is really for that clinical awareness of really what's circulating. And then we have the three largest burden respiratory viruses, flu, RSV, and SARS-CoV-2. And we do genomic surveillance of these. So we do whole genome sequencing of all three of these at the state lab. We have done this for flu for a long time, SARS-CoV-2 since the beginning of the pandemic there, and we're just implementing RSV this year because there are now more vaccines and treatments around for RSV, and so we want to know how that virus is evolving. And so for these are samples that you all send to us, and this is to really track the virus lineages, track the strains, see what emerging strains there might be, see if there are any new novel reassortant viruses for flu or a new variant of concern for COVID. And you probably saw this about a week or so ago. Missouri had a human bird flu case with no link to animals. This H5N1 case was identified through normal influenza surveillance in the Missouri State Lab. So it was a sample that was positive at a clinical lab, sent to the positive for flu A, but unsubtypable. It was not H1N1 or not H3N2 because the test at the clinical lab did test for those and it was negative for both of those. So they said, uh-oh, what is this? Sent it to the state lab. It was H5N1 and then CDC confirmed it. We have a little more information now. Thankfully, the patient didn't have all that many respiratory symptoms. It was more of a GI issue. They were not super sick. They were treated and they were discharged. There were a couple close contacts that had respiratory symptoms, but those who were tested were negative for flu. So we're hopeful this did not kick off the next pandemic. But this is why it's really important for us to do the surveillance, to identify these, to do the investigations of them. And then lastly, we do take a subset of these positive flu, RSV, and SARS-CoV-2 samples, and we send them to CDC. And CDC does really enhanced characterization. They grow up the viruses, they do antiviral resistance testing, they do a lot of other really enhanced characterization that even us in the state labs can't do. And this is a lot of the work the CDC does getting ready to put in newer strains into the vaccines. So that's what we do. That's why we conduct respiratory pathogen surveillance. So a few of the programs that we're involved in, we love this map. This is the NERVS map, the National Respiratory Enteric Virus Surveillance System. I used to think it was called NREVS because that's what it's spelled like, but CDC people tell me no, they say it NERVS. And these are the labs that participate in NERVS. And you can see, obviously, Wisconsin just lights up. And that's because you all are so good at sending us that weekly data. And what we do, we collate that every week. We send that data down to CDC, and we act as a pass-through. A few states do it like us, where the state lab asks for it and then collates it down. But many other states, those individual clinical labs are sending data directly to CDC. And we think that our approach works really well, and many other states are considering doing a similar pass-through approach that we have, but we have a super robust surveillance here. And we've estimated within any given week, somewhere around 30 to 40% of all national data comes from Wisconsin. So thanks. We really have a good sense of what's circulating here. So that's the data side. What about the specimen submission side? SARS-CoV-2, we do send a subset of our positive COVID samples down. That's called the National SARS-CoV-2 Strain Surveillance System for that enhanced characterization. And then we are also a National Influenza Reference Center, a NERC site. It's us, California, and New York, those 3 state labs. So we punch a bit above our weight in terms of size of state and size of population, but we were chosen through a competitive process years and years ago, and we just put in our new 5-year reapplication for this. Basically, all the states in the middle there from orange, the state public health labs from those states send a subset of their positive influenza samples to us, and we do that whole genome sequencing and virus culture and perhaps antiviral resistance testing, basically on behalf of CDC. We're acting as an extension of CDC because CDC pays us to do this type of work. I think I'll skip that one. I've pretty much said that sort of thing. So here is our respiratory specimen submission request. These are the samples that we're requesting, and it's a little busy. We went round and round for how best to show this. So up top, we have pathogen-specific respiratory surveillance, and this is by pathogen, and that whole first half is all flu, because it's confusing in season versus out of season, and then we also split it up by PCR versus antigen testing, but essentially, pay attention to the biweekly surveillance report, because that's where we change it in real time and have that request always there in that every other week surveillance report. Next one down is SARS-CoV-2, and this is a stable, any clinical lab that is doing COVID testing, please send up to 5 positive samples per week. And this has worked really well for us for a couple years. We made a very not good decision in summer of 2021 as COVID cases were really dropping. We thought, okay, we're out of the pandemic, no big deal. It's actually time to turn up the surveillance, and we asked for all COVID positives, like the week before Delta started exploding. And I remember Ray and Eric both emailing me and being like, are you sure? Are you really sure? And so we ramped that back really quickly. Within a week or two, we're like, just kidding, please don't send us everything. But this up to 5 per week has worked really well, whether it's high season or whether it's low season, we still have a good sense of SARS-CoV-2. And then we've added Legionella into this document this year. It's not a new actual request. We and DHS have been asking for this for a while, but it is Legionella isolates, clinical isolates of Legionella, or if someone has a urine antigen positive, please send us the sputum or BAL respiratory sample from that so that we can culture and isolate out. And this is really, we want to be able to get more clinical isolates of Legionella, because often we'll have the environmental isolates from the facility, from a water system, but we often don't have the clinical isolate. And we really need both of them to be able to do that whole genome sequencing to see if they're related, to match it, to identify where exactly people are, which facilities people are actually getting this from. And often we have a lot of environmental isolates and no clinical isolates. So this has previously come out every year in the summer as a DHS memo, and we thought it just made sense to loop it into the respiratory surveillance because we're already asking for other types of specimens. And then lastly, there are a couple site-specific. So University Health Services, we ask for up to 3 respiratory samples per week to have a sense of what's happening on campuses. Sometimes there are pretty bad adenovirus outbreaks or other outbreaks on campus. And then we also have sentinel surveillance. So we have 17 sites around the state that, regardless of if they do testing or what the result is, they send us 3 samples per week from patients that had respiratory symptoms. And that's so that we have an unbiased sense of what's circulating, and so we get some of those samples in with our surveillance as well. That's how we get some of our RSV positives in. And in terms of data and how it's used, it could be a whole talk, and some Yahoo's actually giving a talk in a couple weeks. That would be me. So I'm not going to talk too much about the data for respiratory pathogens, but I'll go over it just a little bit. First off, SARS-CoV-2 genomic surveillance. This is from CDC. Each one of the vertical bars, the big vertical bars, is every 2 weeks from May up until now. And you can see every color is a different different strain. And basically at this point, it's a different sub strain because of all the evolution that's happened within the virus the past few years. And there was a lot of variation back in May or June, and then it's gone down. There's like 4 or 5 of the main ones right now. And this is not shown up all that well, but it doesn't really have to. Basically to say that the virus has continued to evolve. And everything that you're seeing right now is kind of in this upper right-hand part. And it tracks back to the original BA2, and then the original Omicron, the original strain. Basically what I want you to take away from this is we're basically into quote-unquote normal respiratory RNA virus evolution at this point. It's looking a lot like influenza evolution, other virus evolution. Thankfully, we haven't seen a lot of huge switches like from Delta to Omicron. Hopefully it continues along this line and we're kind of settled into whatever the normal SARS-CoV-2 evolution is. For influenza, basically last year was a long season. Often it's a month or two. Influenza last season was December, basically through May. It just kept hanging on. There was H1N1 seasonal, there was H3N2 seasonal, and the green down at the bottom is actually B. So we had all 3 of those. And because they were kind of one after the next, it was just really long. It did not end. SARS-CoV-2 and RSV, we had sort of a bimodal peak there for SARS-CoV-2, and RSV was basically back to normal. Really peaked, started rising in November, peaked in December, dropped in January as flu really became common. So for RSV, we're back to pre-pandemic normal for that. Paraflu viruses, all 4 of them circulated, 3 of them in the spring, or 3 of them in the fall, and 1 of them in the spring. Seasonal coronaviruses, all 4 of them circulated very early winter, or late winter, early spring. And then the past 5 years, we put these graphs in the back of that surveillance plan as well, just to show the impact of COVID. So this is influenza over the past 5 years. You can see big peak, that was 2019 into 2020, and then March 2020, nothing happened. And for a couple years there was no flu. And then 3 years ago, had a little bit of a wimpy season. 2 years ago, a really high season, but really short. And then you can see the most recent one was just long and just kept going. RSV, a little bit similar. You see around 2020, 2021, there's a bit of a, not much there because of all the COVID mitigation measures. And then we had that off-season RSV in the summer of 2021, which was really weird. And that was actually picked up mostly by that nerves data that I talked about before. But we're basically back into normal RSV seasonality now. And COVID, I have no idea. It's kind of all over the place. CDC a couple months ago was saying that they've squinted enough to see a bimodal distribution of an increase in the summer and then a bigger increase in the winter. In our data, maybe. I think we're not quite there yet to really settle into anything we can call a real pattern, particularly with the original strain, then Alpha coming, then Delta, then Omicron. Like, it's actually 3 or 4 very different viruses on top of each other. And I think we're just settling in just to some sort of pattern more recently. All right, another clicker question. Get the lightsaber out again. SARS-CoV-2 results. Is it all SARS-CoV-2 test results, whether they're positive or negative, are reportable to DHS? None of them are reportable to DHS. SARS-CoV-2 positives are reportable, but only for hospitalized patients and pediatric deaths. Or what does reportable to DHS mean? And if you're curious about, if you're thinking D, I put a little thing about disease reporting here. It's basically diseases or conditions that are considered to have really significant public health impact, and every single case should be counted. And this is both the lab should report it if they have a case, as well as the clinician should report it. In reality, it's almost always the lab only because we are well connected electronically, but technically the clinicians should also report. All right, let's see. You guys are pretty good. It is C. It used to be A. It used to be all positives and negatives. Thankfully, we're not there still. It's only positives in those particular patients, hospitalized patients and pediatric deaths. So gone are the days of everything being reportable. And now DHS just last year in September looped in both RSV and SARS-CoV-2 to be exactly like flu has been for a while, where it's only positives are reportable, and it's only in those 2 patient populations. And this is the memo from DHS for COVID-19, and exact same thing, same day for RSV. So trying to make it more streamlined to keep all the rules very similar for all 3 of those viruses. All right, any questions on respiratory before I move on to vector-borne? Yeah?
What's the recovery rate for Legionella cultures or sample that you get compared to urine antigen positive?
Question is, what's our recovery rate for samples from urine antigen positive patients? I don't think we've had enough numbers to really look at it, because every year it's just a handful. Okay. We have a much better sense about Salmonella, Shiga-tox, E. coli sort of thing, where we have like 500 to 1,000 each year. I don't think we have a sense of that, but that's a good, maybe we can look back through all of our years to look at it. It's not 100% guaranteed, but I think we can probably get it out a decent amount of the time. All right, vector-borne. Why would we do vector-borne pathogen surveillance? First of all, to identify and track the species of certain vector-borne pathogens, and also it's really important to track malaria drug resistance, because thankfully we don't have endemic malaria here in Wisconsin, but we do have travel-associated malaria, and the drug-resistant profiles in various areas of the world is changing over time. Thanks, Laura. Thanks, Aaron. All right, so our table here for vector-borne pathogen, this is our submission request, relatively straightforward and hasn't changed from last year at all. So malaria, positives, Babesia positives, and Ehrlichia positives. And the Ehrlichia ones are if your test just identifies Ehrlichia, positive, negative, and doesn't do the speciation, because we would like to know which exact species is circulating, and we'll send those samples down to CDC for that speciation. Vector-borne data, I wanted to highlight DHS website here, www.dhs.wisconsin.gov/tick. They have a huge array of different data for a lot of different diseases. This one right here is Ehrlichiosis, or E. mirus occlarensis, named after Eau Claire. You can see it's very highly distributed in Eau Claire and north, not so much in southern, southwest, or southeast Wisconsin. And Babesia, here are cases per year starting in 2001 up through last year. 2001 was when babesiosis first became reportable in Wisconsin, so every single positive should be reported. And then 2011, there was a bit of a change where they became nationally notifiable. That's where CDC and an organization called CSTE says nationally, essentially state reportable, nationally notifiable are very similar things. And also in 2011, there was a probable case definition. So before it was confirmed cases only were reported, and then it was confirmed or probable cases. And so that's the likely reason for the increase in 2011, but also you can see even from then, there's been a bit of a trend upward in babesiosis cases. And this is not related to a surveillance request, it's just a banner year for dengue, so I had to throw in a dengue slide here. There has been a lot of imported dengue, up to almost 400 positives in Florida alone. And you can see the chart on the left, this is just this year, 2024, quite a bit of an increase, and then it looks like there's a decrease recently. That might be real, or it might just be a data lag, then it takes a little while for the data to get into the systems and to be all added up. So it may or may not be a real decrease in recent weeks. All right, now on to enteric pathogens. So why do we conduct surveillance for enteric pathogens? A lot of different reasons. I should also mention that all these, why do we conduct various types of surveillance? It's not extensive, it's not every single reason why, it's just the main reasons that I've plucked out why. Kind of like for respiratory, we want the situational awareness, what's circulating, what's in season, what's out of season. Also specifically for norovirus, we do some testing to genotype the norovirus because there are multiple different groups working on norovirus vaccines for the future. And they really want to, they have to include the most recent circulating strains to be able to actually have the protection that they need. So we need to know what's actually circulating out there to inform that vaccine strain selection. And then one of the main reasons that we do this enteric pathogen surveillance is to identify outbreaks, proactively identify outbreaks of all these different pathogens. Cyclospora, Cryptosporidium, norovirus, Salmonella, Shigatoxin E. coli, there are others. And the whole idea here is for us to get samples in, to do the whole genome sequencing, to identify samples that are, or isolates that are very closely related to each other. Because if they're closely related, that's much more likely to be part of an outbreak. And then we can talk with Lynn and her friends at DHS and say, these are the ones you should focus on, really go after those, do the food interviews, figure out what's the common source, and get that recall. And she'll talk a lot more about that after me, so I won't go too much into it, but that's the overall approach here, is to do this proactive surveillance to identify outbreaks. It's quite a bit different than with SARS-CoV-2, RSV flu, where it's more of a strain selection, how are things changing over time, not necessarily actively looking for outbreaks of those. So national surveillance programs, we have quite a few. There are a lot of nets in the enteric world. The primary one and the most long-standing one is called PulseNet. And the two of the major bacteria the PulseNet deals with is Salmonella and Shigatoxin E. coli. PulseNet's been around almost 30 years now, and it started with pulsed field gel electrophoresis, PFGE, hence the name PulseNet. About 5 years ago, we switched nationally to do whole genome sequencing because it just identifies things better, has much better specificity and sensitivity for identifying outbreaks. So PulseNet, every single state lab and quite a few local labs do whole genome sequencing on these pathogens, upload everything to a national database to be able to identify outbreaks of these pathogens. CaliciNet is another one. It's not quite as old, maybe 15 years or so, and it's specifically for norovirus. So we do genotyping for norovirus for outbreaks as well as to look for that vaccine strain match. Similarly, CryptoNet, yet another net, similar to PulseNet except specifically for Cryptosporidium. And then the one that's a little bit different is NARMS, the National Antimicrobial Resistance Monitoring System. Bit of a mouthful, but really, they're really interested in antibiotic resistance of all enteric bacteria, particularly Salmonella and Shigella, both in the US and globally. So they do a lot of work with returning travelers from places like Pakistan with XDR Shigella and many other things as well. They really track that AR of enteric pathogens very closely. Here is our table of our surveillance packet that this is our specimen submission requests, and a lot of these are very similar. So Campylobacter, Shigatoxin E. coli, Salmonella, Shigella, Vibrio and Yersinia, and actually the other three too. All of these are the same. They haven't changed at all. What we did do this year is we removed Eromonas and Plesiomonas because we realized that those weren't really needed anymore. It's not really as much of a priority either nationally or statewide. So we're not requesting Plesiomonas or Eromonas anymore. In terms of data and how it's used, one way is to identify outbreaks. And there was a large Salmonella outbreak last year associated with cantaloupes. And this was a weird serotype called Sundsvall. We had never, ever seen Sundsvall in Wisconsin before. And so as soon as we started getting a cluster of Sundsvall, us and Lynn and her friends, we all went, uh-oh, this looks like something, because, and by sequencing, these were all very closely related as well. And it ended up being a decent-sized outbreak. Over 400 people were confirmed to be a part of this outbreak. And that was mostly last year, but we do occasionally still see Sundsvall. It might just be out in the environment, whether or not it's associated with outbreak anymore. And cantaloupe has been known to be a major source of both Salmonella as well as Listeria and other outbreaks as well. I do still eat cantaloupe, but I do wash it well with soap now, and even more so after this outbreak. So that was last year. This year, this is just earlier this month, another Salmonella infection linked to eggs sold in Wisconsin. And this is 42 people in Wisconsin have become sick. Product is recalled, and DHS is asking everyone to look for those particular eggs in their homes. And I wanted to highlight this particular 42 people in Wisconsin have become sick, because I know media-wise this is a good way to summarize it, but this is actually 42 people in Wisconsin who have become sick and went to their doctor, and their doctor took a sample, and that sample was positive, and that sample was isolated either in the clinical lab or at the state lab, and we sequenced it, and it was confirmed to be linked to the outbreak. So at any step along the way, people can get lost. And this is a very well-known, long-standing issue of you're never going to pick up all of the positives. And there's been pretty good modeling by CDC and others to show that it's somewhere around 30 times the number of people who actually are confirmed as part of the outbreak that were really initially infected. So if you take that 42 times 30, we're talking over 1,200 estimated illnesses, which is a much larger amount. This is specifically to Salmonella, and other pathogens might be a little bit different, but just something to keep in mind as you see lay media news that say there's an outbreak of 5 people. No, it's actually 5 times 30 people. The number of people affected are always a lot larger than the number of confirmed to be part of the outbreak people. All right, I'm going to switch to norovirus now. And in 2022, when I did this talk, I talked about norovirus and biofire. And I said there was a Wisconsin clinical lab that switched from another GI panel to the biofire GI. And this was one lab that we had chosen and specifically requested that they send a subset of their positive norovirus to us for that genotyping. We don't want to ask all clinical labs for all norovirus positives. That's as ridiculous as asking for all SARS-CoV-2 when Delta is busy. So when the samples came into us, we run a lab-developed test, norovirus PCR. And with the old panel, we confirmed almost all of them. Yep, also positive for norovirus with our PCR. But as soon as this lab switched to biofire, all of a sudden we could not confirm nearly as many. It was a huge drop in confirmation. And so we said, what's going on with this low confirmation? Could it be contamination at this particular lab, molecular contamination, they're getting positives that we can't confirm? Is this false positives on the biofire? Is that there actually a higher sensitivity of the biofire than of our assay and of the other panel? Or is it something else? And so 2 years ago, we were looking into it with the clinical lab, with the company, which was bought by bioMérieux. And then I said, if anything major comes of it, we'll definitely let you all know. And this past January, there was a recall. So we let you all know through lab messaging. And it says that there's an increased risk of false positive norovirus results. Unfortunately, the company basically said, there's a risk of false positives, continue on. We're not fixing it. Now you know, just FYI. That was really disappointing. They did not come up with any fix. They still haven't come up with a fix, and I haven't heard anything that they're even working on coming up with a fix for this. Unlike Cryptosporidium a couple years ago, where they actually did have an update in the software which fixed it, there is nothing yet for the norovirus aspect. So clicker question, get the lightsaber out again. In addition to norovirus, what biofire GI target has also had issues with false positives in recent years? Is it Vibrio, Crypto, Campy, none of them, or all of them? All right, looks like we're slowing down with the responses. All right, we got a nice distribution here. Those who chose E are correct. It is actually all of them. Personally, I think the biofire panels, a lot of them are really good. The blood culture ones, the ME panel, a lot of them are really, really solid. With a matrix of stool, I'm not sure that this particular panel is a great idea. There's no probe for the specificity in there. It's multiplexed. It is nested PCR. We've had a lot of issues with false positives. So now I'm going to talk about Campy, and this might sound a little bit familiar. We had a lab that switched from another GI panel to biofire GI, and then all of a sudden they noticed that they were getting a lot of culture negative results from our testing. So before it was upwards of 90% or more confirmation that we got Campylobacter isolates out. This, as soon as they switched, it was less than 50%. It was a very big difference. So that their send-out people actually noticed, like, hey, this is a lot of culture negatives from state lab. They first asked us, did you guys change something in your culture aspect? I said, no, we haven't changed anything for years and years in that. It might be something with the test. So again, we're looking into what might be the reason for the confirmation. I'll cut to the chase. It's likely false positives of Campylobacter. We're currently investigating with the clinical lab, state lab, and bioMérieux. We have a WSLH fellow, Annie, who wrote a nice paper that is currently going through CDC review. And again, if anything major comes of it, we'll let you know. It's probably going to be a false positive Campylobacter issue as well. So we have norovirus, we had Crypto a couple years ago, and Campylobacter. All of these issues, they just happen to be with biofire GI. We didn't specifically go out targeting biofire GI. I actually wrote a paper during my fellowship singing the praises of biofire GI panel and how it can improve patient care with the higher sensitivity and faster results for the whole panel. The point I want to make here is that this was discovered due to the surveillance testing that we're doing and the enhanced characterization that we're doing. And this isn't the primary reason for why we set out to do surveillance, but it is a happy little byproduct that we are able to identify issues with commercially available tests that you all use for patient care. And so it's a nice way to show how this also has that benefit as well. Also, please, if you ever see something weird, whether it's norovirus or Campy or anything else, let us know. We really want to help clinical labs with these types of investigations. Quite a few years ago, there was another, I think it was ID Now false positive flu Bs. And so we helped a couple of labs around the state identify that and kind of troubleshoot that because they had seen something like 20% positivity for flu B in June when the rest of the state was like 0%. So if you ever see something weird like that, it might be an issue with the test. We're happy to help troubleshoot things, and we often have these additional confirmatory or enhanced characterization tests to be able to offer. All right, questions on enterics? Yeah?
I don't really have a question, just a comment. And I mean, kudos to everyone in this room and to you guys, because I mean, if you see all of those product recalls, they're all coming out of initiated from Wisconsin, right? I mean, for the most part, it's work that all of you guys are doing and that you guys at the state lab are doing. So there truly is value to sending all those samples to these guys, and it helps our patients immensely. So kudos to all of you.
Thanks. And yeah, we are able to reach out to our friends in other state labs and say, hey, we're starting to see this. What are you seeing? Minnesota also is seeing a similar Campylobacter biofire GI thing right now, which gives us confidence that it's not just us or it's not just the clinical lab we're working with. Like, this is probably a larger issue. And there is that additional, when it's multiple other states and CDC coming together to say, hey, this is an issue, FDA and or the company listen a bit more than if it's one-off lab here, one-off lab there. Everyone, when they have an issue, should still report it, but it is nice to be able to kind of gather the troops and to say there's really something going on. Yes, Alana.
That just reminded me, as we've been working a lot with BU Mariu through these different issues, we learned that their level of investigation starts with the number of reports that they get. It's not an individual report from a big source, it's the number of times it gets reported. So please, if you guys see these issues, please have a low threshold to talk to them and let them know, because they're counting the number of times these issues are being reported to take action.
Alrighty. So now on to AR. Yeah, we're doing okay on time, but I'm going to skip this because most people here know that antibiotic resistance is an issue. Because of that, AR Lab Network was stood up back in 2016 by CDC, and the overall goal is for rapid identification and containment of resistant pathogens, the most resistant ones. You've probably seen this map before. This is how the ARLN has divided up the country, and every state lab does a certain level of testing for antibiotic-resistant organisms and gets some funding by CDC for that, but not all that much necessarily. A lot of the funding goes to the 7 regional labs, of which we are one of them. So we do testing for 6 states in the Midwest, those ones in the purple, and we do a lot of testing for this. This is a very busy area of our lab. Specimen submission requests, we basically have the exact same request as CDC recommends. So we're interested in anything that's resistant to everything. If an organism is resistant to every drug that you tested it on, we want pan-resistant things. Thankfully, that's not all that common. Candida auris, we definitely are interested in, and I'll talk more about that later. I want to highlight, this is the one change you made this year. We're only asking for Candida auris. Before, we also had a request for any really weird Candida species, because CDC was also interested in finding, quote unquote, the next Candida auris. But after many years, it really is Candida auris. It's the one that's continuing to spread and continuing to be a big issue. So that's really what we're focusing on, and not the very weird other species, or less common other species. And then we have Enterobacterales, and I'm going to skip down Pseudomonas aeruginosa and Acinetobacter baumannii. Anything that's resistant to carbapenems, these carbapenem-resistant organisms, we kind of loop those 3 together. The one that I skipped was Staph aureus that's non-susceptible to vancomycin, so vancomycin-resistant Staph aureus. These are still very, very rare, thankfully. I think less than 20 total cases ever in the US, and we want to keep it that way. A couple years ago, there was a positive in North Carolina, and they did a big investigation and containment measures to make sure that that didn't spread. And that's what we want to do every time, because if we have vancomycin-resistant Staph aureus across the country, that's not a good thing. And then lastly, CDC is interested in Aspergillus fumigatus to do some antifungal, actually, susceptibility testing on that. We don't do that, but we send that to Maryland because they were chosen to do that. And so if you have invasive A-fume isolates, you can send them to us, and we'll forward them on to Maryland for that. So data and how it's used, I'm going to walk through a few different of the main bugs that we look at. This is from the CDC threat report from 2019, which is why it's called carbapenem-resistant Enterobacteriaceae before the switch to Enterobacterales naming. And this is an urgent threat. On the right there, you see it's kind of highlighted there. The little arrow thing is on the right, or on the red. That means this is one of the most urgent threats that were identified by CDC. And so for CREs, we do a CARBA-R test for colonization testing. You can see that the numbers from 2020 up through last year have definitely increased quite a bit. And we see a decent number of these in Wisconsin as well. These are from isolates that are so clinically relevant isolates that are sent into us, and then we do enhanced characterization. The red are the number of KPC, which is still our most common, but blue is NDM right there. And this is last year, 2023. Previous to last year, we had about 5 or less NDM every year in the state. So we've definitely seen a bit of an increase in NDM, and this year, 2024, so far, also seen a decent number of NDM. Most of these are seen in the southeast part of the region or part of the state, but there have been others in many other regions as well. And then just awareness, Klebpneumo is the species that we see KPC and NDM in the most commonly. Next one I'll talk about is Candida auris. Again, an urgent threat identified in 2019 as an urgent threat by CDC, and this was even before it really exploded a lot. So the first couple years of ARLN, Candida auris was really not that common. It was only in a couple of different areas. New York City and Chicago were 2 of the hotspots. Now it's really spread widely, and we have many Candida auris in all of the 6 states and even in the Midwest. So it's a highly drug-resistant yeast. It can cause invasive infections, particularly in immunocompromised patients with high mortality, and it does spread easily in healthcare settings, hard to get rid of once it's there. So this is the number of isolates that we've tested over the years from 2019 through last year. And you see a bit of an increase, and this is even within 2022 and 2023. Illinois sort of just stopped sending us isolates. I don't know if they gave up or whatnot, but Illinois was our highest submitter of isolates, and even without that, we've seen an increase in the number of clinically relevant infections of Candida auris.
They told us to stop sending them to IDPH.
They told you, so Eric said they told clinical labs to stop sending them, so they did kind of give up because there were that many of them. Yeah. Yay. All right. Next question here. What is the best empiric treatment for Candida auris? Is it fluconazole, micafungin, or amphotericin B? And while we're waiting on the last couple, I want to highlight Megan Lazier here. She was the one that put all this data together for AR. So thank you, thank you, thank you. Looks good. All right, I think we're slowing down. And what are we looking at? Did I click it too fast? Ooh, nice equal spread. We will see. And I'll keep you in suspense because I'm not going to tell you yet. So this is some data, again, that Megan put together. It's a great way to show it all. So we have MICs on the bottom, going from low to high MIC, and then the number of isolates on the y-axis. The middle red dotted line right there is the provisional CDC breakpoint. There are no CLSI breakpoints for Candida auris. This is for fluconazole, and then the colored bars are for each state. So you can see which states have sent us a lot. Thankfully, we don't have that many in Wisconsin, but unfortunately, that's starting to change as well. I'll get to that in a little while. Ohio, Michigan, and Illinois have sent us the most, but Illinois has sent us many fewer recently. So that's fluconazole. So fluconazole, not great. Almost all of them are resistant. Vast majority are resistant. This is one of the main reasons why Candida auris is a big worry, because it's resistant to almost all of them are resistant to fluke. Amphotericin B looks quite a bit better. So there's a few resistant ones, but the vast majority are pretty low, MIC of 1 or lower. And here's the micafungin one, actually even a little better. So the vast majority are susceptible dose dependent is what CDC calls it. We do have a couple few over here that are resistant, and we retest those at least once, if not twice, to make sure that those truly are resistant. But we also have a few other echinocandins on the panel, and generally they all track together, so it's pretty easy to tell if it's micafungin resistant. It's also resistant to the other echinocandins as well. So based on that, micafungin is the best empiric treatment because nobody wants to treat anybody with amphotericin B. The side effects are just too bad. All right, so for Candida auris, if we identify a positive isolate from a patient, what do we do next? First off, treat them if they really need treatment. But then also, really what ARLN is doing, and a lot of the testing we're doing, is to identify and prevent transmission. And for this, we do colonization screening. This can be for many different reasons, and I've listed a few of them there. We could do either contact tracing around a newly identified case. We could do a whole point prevalence survey of a whole wing of a facility, or even a whole facility if it's not that big. We can do admission screening if there's a long-term care facility with a known Candida auris in there and someone from that facility needs to go to an acute care hospital. They could be screened as they're being admitted so that we can know which type of precautions to take at the hospital. And the main goals here are to determine if there's already been transmission from that clinical case, and also to initiate contact precautions on colonized patients to prevent further spread. And it's an axilla groin e-swab, because this is a skin bug, and that's the current CDC recommendations. May change in the future based on updated data. And this is where it gets kind of crazy for us, at least, as the Midwest Regional Lab. Here are the number of Candida auris tests that we do per quarter from 2019 through 2023. And it's continued just up and up and up. Originally, for the lab people, this was a culture-based test, a CDC-developed culture test that took 14 days for a rule out. Not really that useful for really ruling out spread. So then we developed a PCR that was very manual and very low volume, and then we developed a bit more higher and then higher. But even in 2022 and 2023, we were still running deep well 96 well plates, manually pipetting for its extraction, and then going to a 96 well plate, manually pipetting for PCR as well. And it felt a lot like early days of COVID. It's like, this is not sustainable, not what we want to do. So what we did for COVID was to switch to automated platform. We used some COVID money to buy Panthers. And this is exactly what we did with Canada Auris as well. We used Panther Fusion, did an LDT PCR, much more hands-off, much more automated, and we can better handle the volume. It's still not great when we get a FedEx shipment of 200 swabs all at once, but it is much more doable now. So here we have Canada Auris cases. This is just in Wisconsin. And so the red ones are clinical isolates, and the blue bars are screening positives. And I want to highlight, previous to 2021, that first case in 2021, it was 0 for the history of time. We had none. But then we had our first case in 2021, 2022, just a couple, not great last year. We had quite a few more clinical cases, did some screening, and especially toward the end of last year, found quite a few colonized patients as well. 2024 is kind of the same as 2023. Better, worse, the same? What do you think, Megan? She has the most up-to-date. Okay. Same/worse? Yeah. Okay. So we're still talking low numbers total. This is only 2, 4, 6, 8 here. But considering it was none for the history of time before that, this is concerning that we're seeing an increase and not a decrease this year either. So that's where we are with Canada Auris. Last one I want to talk about is CRAB, carbapenem-resistant Acinetobacter baumannii. Again, it's an urgent threat as identified by CDC. These cause many different types of infections in the ICUs in particular. We often have these plasmid-coated beta-lactamases called OXA23, 2440, and 58. And these are, they were called this because they have oxacylinase, they can cleave oxacillin, but also they really they're as bad as CREs because they make the organisms resistant to pretty much every beta-lactam. And here's another chart showing how busy our AR group is. This is crab colonization testing, and we did almost nothing in 2020, but we've continued to see a huge increase here as well. This is still culture-based colonization. It was WDL quite a few years ago, pre-COVID, that developed this because of an outbreak of crab in the southeast region. And it's a great test. It's really sensitive. It's great for low numbers, but it's really manual. And so we're currently working on implementing a PCR test on the Panther Fusion, just like we did with Canada Auris. A little bit of crab data here. This is in the Midwest. What type of carbapenemases we see? Almost every single one of our resistant crab has either an OXA23 or an OXA24. A little bit different from CRE, where if we have carbapenem-resistant CRE, maybe 20% of them are positive. And Pseudomonas, I'm not even talking about, because less than 2% of our Pseudomonas that are resistant to carbapenems actually have a carbapenemase as the mechanism. So it's both OXA23 and 24. This is just Wisconsin. Almost all of them are OXA2440. They're really similar type of organisms. And we have seen, again, primarily in the southeast, but we have over the past 5 years seen a decent amount of spread to other areas of Wisconsin as well. All right, any questions on AR pathogens? Yeah?
Just in general, I have a CPO who's an insomniac who doesn't sleep, so he reads lots of articles, and I've been trying to find data from, so the CREs you guys are getting submitted, where is it coming from? Like, what infections is it being isolated from?
Megan, you want to answer that one? Here.
We
The question is, what specimen type are the Canada Auris invasive infections?
Yeah.
So we're actually working on putting out probably a quarterly report that will have that data in it. But we see a lot of urine. We see some respiratory. We see some wound. It's kind of and blood. I would say urine and blood are probably the most common. All
right, last one here. We'll end up pretty much on time, Aaron. Sorry if I go a little over. But invasive pathogens, this is a bit of a grab bag other. We might even change the name to be other. But most of these are actually invasive pathogens. So why do we conduct surveillance here? And this is kind of a grab bag of reasons because it's different for each of the organisms. So we also do Listeria and Chronobacter. Chronobacter is new this year. And very similar to PulseNet, Salmonella, E. coli, we want to identify outbreaks of those. We want to do subtyping and genotyping to track the subtypes and genotypes of strep pneumo, H. flu, and N. meninge so that we can make sure that the vaccines that exist for those are actually matched with what's currently circulating. We want to identify trends in enterovirus genotypes, enterovirus D68, but also many other ones. Yes?
I have a question.
Oh, sorry. Back to Canada Oris.
When you're putting out the data, are you also, like when it comes to urine specimens, specifying which ones are coming from cath patients?
If we get that data, yeah, but we don't, like urine catheter?
Yeah.
Honestly, it probably hasn't been that many, but we only have like 40-something cases.
Okay, it's just, so, I was just curious because like my other job is on an ambulance, and we recently had a patient who self-caths who came in with like urinary sepsis, but I can kind of see him as a self-cather picking up something because he doesn't do it in the best conditions, like whether or not that would be a consideration for the data.
I would say a lot of these are also coming from long-term or congregate settings, so you have the environmental risks associated with those as well.
Yeah, so I would say a good portion of our patients are
Further from you.
are in long-term care or being helped with that care, but I think it is a concern. We do ask about indwelling devices in our surveillance in WEDS. So,
Thank you.
Okay. Everybody has to, when you're using the microphone is by your mouth. If you hold it down here, he's turning it up really high to get it, and then you're getting the feedback. So please put the microphone by your mouth. It won't bite you. Thanks.
Sounds good. How's this? Can you turn it down now? Okay. Next, we want to track the trends in species of blastomyces. I'll talk about that in a bit. And then we always have this request of if there's anything weird, let us know. This is going to be a little old now, but Elizabeth Kingia in 2016 was a weird outbreak, actually never really solved, but it did kind of peter away on its own, thankfully. But this is another request. When you see anything that's out of the ordinary, let us know. We're happy to help investigate it, and it might be a new outbreak of something. All right, so statewide and national surveillance programs. We do have an invasive bacterial lab surveillance program. This is that H. flu and meninge and strep pneumo. And we do additional genotyping and serotyping for these. And then nationally, we're part of the Vaccine Preventable Diseases, or VPD, reference centers. And this also is similar to sort of things where we do PCR and subtyping and genotyping both for viruses, measles, mumps, rubella, and VZV, and bacteria, those same three. So for the viral side, we are one of 4 state labs that were chosen to do this. And on the bacterial side, it's just us in Minnesota. We essentially split the country down the middle at the Mississippi. Anything east, we do the testing for. Anything west of that, Minnesota does the testing for. Blastomyces. So blasto is a dimorphic fungus that's endemic to North America, just like histo and cocci. It's kind of in that realm of things. The thing about blasto, though, is we are the hotspot. We have 10 times more blasto than any other state. And there are outbreaks quite frequently. But we don't know all that much about blasto because it's still not super, super common. There was just the largest outbreak ever just happened last summer up in the UP. And Alana and others are still investigating that, looking into it more. So as part of this, we were actually CDC funded to add a new blastomyces surveillance aspect to our surveillance. So we're requesting that all isolates be sent from all blastomyces isolates be sent to us. There's about 150 total reportable cases per year. So we're thinking this isn't too much of an additional ask because we know a decent number of those are from out-of-state labs as well, and we're probably not going to get those. But we will do initially species level moldy tough identification, and then the plan is to do additional characterization in the future on these as well. Anything to add, Alana? Okay. She loves blasto, that's why I asked. Chronobacter is a new thing this year too. CDC, it's a new nationally notifiable disease and statewide reportable disease. So Chronobacter sakazakii used to be an enterobacter, and it really loves to live in powdered dry infant formula. It doesn't cause all the many infections necessarily, but the ones that it does are often in the very tiniest little babies. And often, I think I saw up to 40% death rate in this group of the positives. And they are now nationally notifiable and reportable. This is just this past March, the DHS memo making it statewide reportable. These are invasive Coronabacter infections among infants are now reportable. So get those lightsabers out one more time. How many cases of invasive Coronabacter are there in the US each year? Is it 0 to 10, 10 to 100, 100 to 1,000? We don't know. Or do you mean coronavirus? And I will say, when we first started talking about this early this year, it was hard for me to get out of my brain just saying coronavirus, because I've said it a billion times over the past 5 years or so. But this is Coronabacter. All right, survey says, nice spread. Okay, those who chose D were actually right here. We don't really know. And that's one of the reasons why we make it nationally notifiable and statewide reportable, is to get an idea of how many there actually are. So CDC has said they typically receive about 2 to 4 infections, reports of 2 to 4 infections in infants per year. But before this year, it was only Minnesota and Michigan that had it reportable. So we really don't have any great idea. Probably not all that common, because we don't see it super commonly in infants in clinical labs, but we really don't know, and that's one reason to make it reportable. And we're also adding a specimen request for this so that we can do whole genome sequencing, just like we do for many other pathogens, to identify outbreaks and be able to get implicated products off the shelf. All right, on to enterovirus. A little bit of history. Back in 2022, there was a gigantic peak of enterovirus D68, and D68 is known to be associated with acute flaccid myelitis, or AFM, which is a polio-like disease that was originally identified back in 2014. There's kind of been a 2014 peak, 2016, 2018, every 2 years, until 2020, and COVID obviously totally changed everything. But there was this big peak in 2022. They looked at over 5,000 children who were in the ED with acute respiratory illness, and almost 20%, almost 1 in 5 of all kids tested had enterovirus D68. So really big surge of enterovirus, and there was this really large concern that in the coming weeks to couple months, because that's how long it takes for the AFM to develop, there was going to be a big surge in this AFM as well. Thankfully, that did not happen. Very happy surprise. Here you can see on the top, 2014, 2016, 2018, almost nothing in 2022, maybe a little bit of blip. But that really made CDC go, okay, we don't know what we're talking about with EVD68 and enteroviruses in general. Also, there's a lot of other enteroviruses out there that are not EVD68. We don't have visibility into what's actually circulating and what type of disease it's causing. So there's new national enterovirus surveillance, and because of that, we're asking for CSF positives for enterovirus. This past year, we tested some of our own respiratory samples that were rhino/entero positive, RV/EV positive. They're almost all rhinovirus positive, no surprise. So we only got a couple enteroviruses in the respiratory tract, so this year we're trying to limit it more to the really invasive ones that are CSF positives, that we know it's enterovirus positive only because the test only detects entero. Here's the list of invasive pathogens, similar to previous years: H-flu, Listeria, N-menin, Strep pneumo. The Coronabacter is new, enterovirus is new, Blastomyces is new, and then the 2 at the bottom are anything weird, let us know, basically. So invasive pathogens, the data and how it's used. You probably saw this boar's head deli meat recall due to Listeria. This was a very bad outbreak. And Listeria is a little bit like Coronabacter, where probably not as common as Salmonella or Shigatoxin E. coli, but the infections that do happen can be really, really bad, really deadly. And then we really just want to avoid any infants dying from Coronabacter. Bad disease, let's identify outbreaks and get those implicated products off the shelf. And lastly, N-menin, I just want to throw a little bit of data here. The line there is the incidence of disease. So over time, 2011 to 2021, looks great. But unfortunately, the bars here are number of resistant isolates. And the light blue is just resistant to Cipro, and the dark blue is resistant to Cipro and penicillin. So we're seeing an increase in Cipro, penicillin, dual-resistant meninge as well. Because of this surveillance data, CDC now has new guidelines and new strategies, both for treatment, for prophylaxis, and for surveillance as well. So we do use this ongoing surveillance in order to update guidance for patients. And new this year, we have this updates for this season to show, really highlight the differences that we have from previous years. So C. diff I mentioned, backed by popular demand, the data. Legionella, exact same request, but we've just looped it into this all surveillance plan. Chronobacter is new. Enterovirus just in CSF is new. Strep pneumo, we actually decreased our request. Before it was all invasive strep pneumo, but now we really only want those that are antibiotic resistant or thought to be part of an outbreak or a vaccine failure. So it should decrease the number of isolates for strep pneumo. Blasto is new, and then we're no longer requesting Ehrlichiosis or Plesiomonas. So a few things added, a few things taken away. We think overall it's a bit of a wash. We really think deeply about this and don't want to overburden you with all of our requests. So we try to make it as streamlined as possible, even though we do all this cool stuff across all these pathogens. And with that, I'll say thanks. Your guys' participation is absolutely critical to everything that we do. And with that, may the force be with you. I'll take other questions.
Are there any questions for Al this morning? Anything about surveillance we didn't cover? Here, I'll give you a mic.
For blastomyces surveillance, is it like one per patient?
Yeah, I think one per patient should be good.
All right, just making sure.
Any other questions? All right.